So welcome all participants to this 10th ISG webinar. I think this will become a very, very great webinar. Let me give you very few information before Mark Smet takes over. As you know, when you're now watching, you will get an evaluation sheet finally, and you have to send this back, please. We need that for the CME accreditation. And then after this one, you will get the documents of participants for this meeting and also the CME points. Mark, I think you should take over. That's fine.
Okay, well, thank you, Manfred. It's a pleasure to have so many people already join us. And today's theme is going to be differential diagnosis of uveitis and the role of multimodal imaging. And we have 4 different topics, as you've probably seen on the program. One is regarding imaging for the anterior segment, imaging for retinal vasculature in the posterior uveitis. Old but gold, and this should be interesting to see what we have there in this face-off, and then cutting-edge imaging in uveitis, which of course is the future. And so we're going to have discussions after each, for each of these sections, there are 2 talks, and after each talk, we'll have a short discussion. And if you have questions, do send them through, and we'll try to answer what we can, but we won't answer each of the questions in the chat this time around. So we'll start with imaging for the anterior uveitis, and the first speaker is Alessandro Invenici, and he'll be talking about the cell automated assessment of anterior chamber inflammation. Alessandro?
Yes. Like for inviting me to talk about an interesting topic in this wonderful webinar. If you can see my screen, I can start. Can you?
Yes.
Okay, so these are my disclosures. Let's start with a bit of a background. So we all know that to assess the inflammation in the eye, we use the recommendation of the Sun Working Group, and they stand still since 2005. And for the anterior chamber in particular, we grade AC cells and AC flare. Now, AC cells are graded with a scale from 0 to 4. And we know that to do that, we count them in the anterior chamber with our slit lamp examination. And the flare, once again, is from 0 to 4. And to do that, once again, we use the slit lamp and we try to grade the clarity of the aqueous according to the details we can see about the iris. Now, we all know that these are the current grading scales, and they are very good because they have lasted for like 20 years now, but they have some lacks. First of all, they are subjective, they are non-continuous, and there is low agreement between graders when we use them. And this is true for all the 3 scales that we have, both the ones for the anterior chamber and the one for the vitreous. So the problem affects both the routine clinical practice and the clinical trials. In particular, when we speak about our everyday clinical practice, the intracellular agreement is low. So we need to check the patient. Maybe more than one doctor has to check the same patient to determine the grade of inflammation, or we can have disagreement at different visits if it's not the same doctor assessing the patient. And of course, when we have to follow treatment guidelines, we need to know exactly if the patient is getting worse or getting better. And having disagreement, it's obviously a problem. And in clinical trials, this is even worse because we need to have, for example, 2 steps improvement to determine whether a drug is actually effective or not. So the question is if we can make these measurements more objective and if imaging can help. Now, if you go back in 1997, imaging was used, and this is an example of fluorescein angiography, to assess the inflammation in the anterior chamber. And this is an iris angiogram showing some leakage at baseline and then no more leakage at follow-up. But of course, we don't use these. We haven't been using these, so it was a good attempt, but it did not find any practical use in the clinical practice. But nowadays we have new technologies, and new technologies obviously offer new possibilities. So the first one, of course, is anterior segment OCT. And we see here that back in 2015, the group from the Cleveland Clinic proposed a grading of the anterior chamber cells based on OCT imaging analysis. And this grading was actually discounting of the cells was automatic and was actually matching very well with the clinical grade. And another group also assessed imaging, assessed the cells in the anterior chamber, and they found that they could actually somehow recognize the type of cells according to the size and the reflectivity. What about the flare? Well, we know that flare usually assessed with laser felt photometer, and Marion will speak about this after me, so I'm not going into details. But the question is, can we measure flare on OCT? Well, in 2014, Piers Keane and Alastair Denniston described a technique to grade the vitreous, and they basically tried to assess the reflectivity of the vitreous and to compare it with the reflectivity of the RPE. And this is in the back of the eye, of course, but the same principle can be applied to the anterior chamber. And in this paper, we assessed the cells and the flare on OCT of the anterior chamber. And how we did that? Well, of course, we counted the cells because they're pretty easy to be visualized. And we obtain the same results as the group of Sunil Srivastava. So we basically had a good agreement between the cells counting and the clinical grading. But we also assessed the flare. And we did that by comparing the average brightness of the anterior chamber and the average brightness of the air outside the eye. And this allowed us to create an index reflecting the flare. And interestingly, even if our eye is not able to see any difference between these two images in terms of the reflectivity, after correcting for the air reflectivity, the final index gives us a different score. And this index actually performed quite well because it matched quite well with the laser flare meter measurements and with the clinical grading as well. On top of this, we know that anterior chamber OCT can actually allow us to see keratic precipitates. There is no actual standardization for the counting of these, but definitely we can see them and we can somehow track them over time. And this is just an example of one of our patients. You see that there are a lot of cells in the anterior chamber floating around, and we see granulomatous keratic precipitates as baseline. And then this is a week after starting the treatment. And you see that both the keratic precipitates and the cells are decreasing in number. So what about OCTA? Well, we know that OCTA is not able to see the leakage. And this is an example from a vasculitis, an exudative vasculitis in the back of the eye. But if we wanted to use OCTA in the same way they use the fluorescein angiography to see the leakage from the iris vestas, of course we cannot. But we know that OCTA can actually visualize the vasculature of the iris quite well, especially the latest released instruments. Like in this case, we see a patient with CMV retinitis and iris ischemia. And you see that we can see the progression of the disease with OCTA. And in this beautiful review from Francesco and others, you see that OCTA can actually be applied to several conditions in the anterior chamber of inflammatory disease of the eye. And in particular, what he describes is that according to the grading of the inflammation, so 1+, 2+, 3+, 4+ cells, the vasculature of the iris, we may not see the leakage, but we definitely see larger vessels. So vessels increased in density and in size. Even a more advanced technology allows us to assess the volume of the vasculature in the iris, and this actually increases according to the inflammation inside the eye. So they also tried to find a correspondence between the sun grading scale and the OCTA measurements, and as you see here, they match pretty well. So the future is probably seeing an automatic assessment of the anterior segment inflammation, and this is probably going to be done both counting cells, maybe assessing flare with OCT, and definitely using also OCTA to assess the vasculature of the iris. So to conclude, we need to have more accurate, objective, and repeatable measurements of the intraocular inflammation, especially in the anterior chamber. And imaging seems to be the key to obtain such a result. Obviously, the revolution has just begun, so we need to wait the next few years to have these in our clinical practice. And I thank you for your attention.
Thank you very much, Alessandro. We'll go on to the next talk, and then after that we'll come in. We have a few questions that are coming in, so we'll keep those for the discussion. So the next talk is by Marion Monk, and she'll be talking about the reservoir dog automated flare assessment for anterior chamber inflammation. Marion?
Thank you, Mark. 1 second, let me share my screen with you and my presentation. All right, can everybody see my presentation?
Yes, Marion, it's very clear.
Thank you, perfect. So now you've already heard Alessandro talking about the possibilities of imaging by quantifying anterior chamber cells and inflammation in the eye. I will touch a little bit based on the automated assessment of flare for AC inflammation. My financial disclosures. So usually we're in daily clinic, especially if you're not in uveitis clinic, you're mainly assessing the anterior chamber cells. And people are actually, even when it comes to slit lamp assessment of anterior chamber flare, they are not as experienced as in assessing anterior chamber cells. And so in terms of anterior chamber flare, there's even a higher interobserver variability than with anterior chamber cells, because people are not as experienced and as used to accessing it and assessing it. We've already seen from Alessandro that when you assess anterior chamber cells, you have the Sun working group grading scheme, which uses a 6-point or 6 categorical assessment of the severity of the inflammation. And when it comes to the reliability of this assessment, you know, and we've already heard this, that it's very subjective. It's non-quantitative because it's a categorical assessment. It's unreliable, and unfortunately, it's also poorly sensitive. Nonetheless, it's one of the most important severity assessment factors we have to assess the inflammation in the anterior chamber. And when it comes to anterior chamber flare, it's quite the same. We have a 5-stage categorical assessment grading scheme here, and also here, it's subjective, it's not quantitative, it's unreliable and poorly sensitive. And when we look at these parameters we use, we already see the problems we have here in daily clinic, but also in clinical trials, because it's very hard because of the fact we really only have 5 or 6 categorical variables. It's really hard to assess whether a patient improved under the treatment, whether he worsened, whether he needs additional treatment. And also, if you want to assess the efficacy of a new drug, it's very hard to assess it, because in order to reach the primary endpoint in all these clinical trials, you have to see at least a 2-step improvement. And when you now imagine that we have a 5-step categorical measurements or a 6-step categorical measurements, you can already see that this may be quite challenging to really reach a 2-step improvement here. Nonetheless, we know that laser flare assessment on top, and in addition to not laser flare assessment, also flare assessment, on top of the anterior chamber cell assessment is very, very important, because previously and in older days, people assumed that flare and chamber flare and anterior chamber flare is rather a function of disease duration, but it has been shown that it's really a marker for disease severity and disease activity. And what is also important, that it is an independent risk factor for any development of complications of uveitis. So it's really an important risk factor and an independent risk factor on top of AC cells for the development of secondary cataract, posterior synechiae, but also glaucoma and band keratopathies. And it's associated with an increased risk of vision loss and development of new vision-threatening complications. So what is laser flare photometry? So laser flare photometry in general measures the amount of light scattered from particles. So what does it do? So you have the coherent light from a laser diode is sent to the anterior chamber of the eye, and then the light, which is backscattered, is measured and quantified by the device. And this amount of backscattered light is proportional to the concentration and size of protein in cells in the aqueous humor. And you can already see then it's a quantitative outcome measures. And the outcome measure here is photon counts per milliseconds. This is just an example from our clinic. This was a patient with granulomatous uveitis, which came in. He had 0.+5 cells. We started the patient on steroid eye drops, and at the next visit, the AC cells was still plus 0.5. We continued the treatment, and at the third visit, the AC cells were still plus 0.5. So you don't know yet, is there no response on treatment? Don't we treat enough? So what is really taking place and what is happening here? And if you add here the laser flare photometry assessment, you see that at the initial presentation, the patient had an average photon counts of 36 photon counts per millisecond. Then after starting the treatment, the laser flare dropped to 27. And then after continuing the treatment, you see that the laser flare further dropped to about 19 photon counts per millisecond. So you can already see that there is a response. You still need to continue the treatment to get down to normal values, but you have a better understanding how the patient is performing and how the treatment is really working. What was also shown is that, as I've already said, and also Alessandro has shown you, that there is a high disparity in flare readings between the individual clinical graders. And in about 44% of the eyes, you will find the disparity of at least one step disagreement when physicians assess anterior chamber flare. There is a better concordance if you look at expert graders, and also as you can show that there is a reliability on the laser flare measurements, because when you compare the laser flare assessment with the anterior chamber flare assessment from clinical experts and uveitis experts, you see that there is a concordance and an association. And what is also very important is that if you add laser flare photometry to the assessment of a patient, the management is regularly changed based on the assessment of the laser flare photometry. So it's really a valuable tool to remove observer bias and to titrate therapy. And what is also a benefit from laser flare, automatic laser flare assessment, that it can allow to catch early changes before you really see anterior chamber flare on slit lamp exam. So you need at least 30 photon counts per milliseconds in order to see at least 1 point flare in the anterior chamber. So you already have some inflammation, and if you use anterior laser flare photometry, this really helps you to identify diseases and activity and inflammation activity earlier, prior you see anything on slit lamp exam. And so it can help you really to identify early intraocular inflammation or endophthalmitis after cataract surgery, or for example, after an intravitreal injection. This was, again, another example of our clinic. This patient was regularly treated. I think she had in the past 20 aflibercept injection and 2 PDT treatment, and still showed persistent subretinal fluid under four weekly treatment. And so we decided together with the patient to switch her to brolucizumab. And after the first injection of brolucizumab, you saw that there was a decrease in subretinal fluid. So we continued her on the drug. But unfortunately, after the second intravitreal injection with brolucizumab, the patient developed some flare. And in the laser flare photometry, we didn't see any flare in the slit lamp exam, but on laser flare photometry, we saw that the flare has increased to 25 photon counts per millisecond. So we switched the patient back to aflibercept. The patient did not receive any additional steroid eye drops. And what you can see then is after 4 weeks after, again, switching back to aflibercept, you see that the laser flare photometry has come back to normal, to a laser flare, to a photon count of 9 counts per millisecond. And also in clinical trials, laser flare photometry is now slowly being used as really primary outcome measures in anterior uveitis trials, because you've already heard the advantage that it's quantitative and it really allows a more precise assessment of the treatment response in patients. Nonetheless, we know that it's an objective and quantitative measurement, and you can catch inflammation prior you see it on slit lamp exam. And so it's really a precise measurement tool in daily clinic and in clinical trials. Nonetheless, it's only reluctantly employed in routine uveitis practice. And one of the reasons for this is that you need an additional exam for the patients. And of course, you need an additional device, which you have to buy, and which is often costly. And another downside of it, that of course, there are also biasing factors of the quantification of laser flare photometry. So for example, the backscattered light from the anterior cortical lens may also be a bias for the assessment of laser flare photometry. Of course, you can kind of quantify this kind of bias if you do a Scheimpflug image. But nonetheless, then you would need an additional image and an additional device to kind of try to monitor the potential bias of, for example, cataract development, or whether the patient is pseudophakic. So this is definitely one of the downsides. And with that, I would like to thank you for your attention, and I'm looking forward to a lively discussion.
Well, thank you, Marion. And in fact, you're bringing up one of the first questions that came up in the Q&A, and one that I have also is, all of these technologies are fantastic, and I've used this flare meter in the past, and you've identified one of the major drawbacks, I think, is in fact the cataract development. In a study, it might not be a major problem. But when we test new machines, we always test them under ideal conditions. And so, you know, one of the questions that comes up for you, Alessandro, with what you've done, and so you, Marion, with regards to this device, is what are the limitations? And maybe you can give us a bit better idea of what the false positives and negatives can be with these two technologies. And while you're thinking about it, let me just ask one more thing, because you've both said that the grading scales that we've used so far with Sun are no good, and you're right. I mean, you know, they're very subjective. They're just based on a number. But, you know, technology is great. Unfortunately, it can't be used everywhere. And for example, with cataracts, there is a very nice gradation system that exists just by using essentially images and asking people to give a comparative with regards to an image. And, you know, there's an article that just came out very recently that tries to do that with cells, and at least on paper, looks pretty good. So maybe you can give me your idea with regards to that, and at the same time, what are the limitations of both types of technologies? What are the false positives?
So I think to start with, first, it's always easy to say this is not an ideal endpoint, or this is not a good measurement. However, I think if you say something is not good, you should come up with an alternative. And actually, I mean, there are great academic studies on this, but first of all, the limitations, and one of the big limitations is it's nice to have an academic publication which shows you that you can quantify it, but it's not accessible to the vast majority of the people. So either to have something, you really have to inbuild it in a device which is made to kind of quantify these kind of parameters, or you make it publicly available so everybody can use it. And this has to be then irrespective of all the image modalities you use. And here you already have one of the major limitations in terms of this. Another limitation is, of course, these quantitative measures we are using for a reason. And the reason is that, you know, it have been shown on a prospective way that it really has a clinical impact. So, and you really know about when you say you have 1+ cells, you know what's going to happen. And if you keep going, you know what's going to happen in 20 years. All the new measurements which are coming up, they're not tested. They're not tested for reliability. And it's really very hard and also very costly to kind of bring these endpoints really to a regulatory level where people can accept it as a clinical endpoint and also as a reliable clinical trial endpoint. And I think here, these are one of the major caveats here.
So if anything, you're telling me I have to continue doing just my clinical assessment and not go out and buy a new machine. Come on, Marion, I thought you would tell me something else. But if it can be put into an OCT, maybe then I can use my OCT to do everything. So what are the limitations of these techniques, Alessandro? You know?
Well, yes. I think in respect with the cells, the problem is that counting them on OCT is very time consuming. So when you look at the slit lamp and you look at a patient, and if you're a good or a well-trained uveitis specialist, it takes you maybe 2 seconds, 3 seconds to grade the cells. While with the OCT, you have to acquire the images, and that's usually quite fast, but then you have to count the cells on the scan, and maybe on more than one scan. So this is probably one of the great limitations of the cells assessment using imaging. And unless we will have an automatic assessment, so an automatic count of the cells. And the other thing that Marion was saying is that it has to be, available to anyone. Then that's probably what will make these beautiful technology, really applicable to the clinical practice. So it has to be fast and freely available. And in terms of the flare, the flare assessed with the, one of the problems with the laser flare meter was also that it was quite expensive, and one had to buy it and just to perform flare measurement. Now, the attempt we did with the measuring the flare on OCT was to try to bypass at least this point, because most clinics have an OCT, even if they don't have the laser flare meter. Now the problem, and with this I will answer you to the other question. So what's the limitation of the false positive or negatives of the flare assessment with the OCT? We noticed that there is a very large gray zone, especially at lower flare levels. So when you have a very high flare measured with the laser flare meter, then you see that clearly on OCT as well. But when the flare is kind of low, let's say 20, 30, and that's probably when it's more important to distinguish, the flare count, then the OCT is affected by several other factors like, the corneal thickness or, other physical variables that can affect the signal. So that's probably the major limitation again. And yeah, that's it.
So if we look at it.
And also what I wanted to add here, it's like when you assess the flare using these kind of techniques, usually you export it and then you use image J, and then you have no standardized method. So you put a threshold and on it, and this threshold will be different for each individual picture you're assessing. And what, as Alessandro said, I think also, I mean, I think you can use, for example, customized software like Image J or Fuji to automatically count the cells in the anterior chamber. But again, so you won't need to really count it cell by cell. You can do this automatically. But again, I think in daily clinic, you won't do it because it's time consuming to really take it, to export it, and then to import it, and to play around. Nobody's doing this. So it really has to be fast. It has to be something which is inbuilt and which kind of helps you and kind of speeds up your clinic and not further elongating your daily clinic.
So one of it may also be, clinical studies, and maybe in fact, instead of having a continuous variable, sort of grouping it even in terms of using it with the machine might work. Vishali wanted to make a point before we move on. Vishali?
I think we need to move on, and probably Alessandro and Marion can answer the questions in Q&A. They can type.
I think would be a good idea. There are quite a few interesting questions there. So let's move on. The next topic is going to be imaging of retinal vasculature in posterior uveitis. And in fact, the first speaker is you, Marion, and you're going to tell us how to lose a dye in 10 days. Will swept source OCTA replace conventional angiography? I think that's quite a challenge. Well, look forward to seeing what you have to say.
Okay, I'll try my best to convince you. 1 second. All right. Everybody can see my screen?
Yes, Mary.
Yes.
Good. Thank you. Thank you. I just had troubles yesterday, so I wanted to make sure. So I will try to convince you within the next 12 minutes that swept source OCTA can replace conventional angiography devices, more or less. So in summary, and I hope after the next 12 minutes, I will show you, or you will have learned that swept source OCTA can add additional information on top of ICG and fluorescein angiography, and it can replace FA and ICG in some clinical settings. But overall, it does not replace other angiographic methods. First of all, the first question is, does everybody has access to OCTA? We leave the swept source part aside from now, yeah? And when you look at the ASRS survey, unfortunately, I haven't found anything in terms of uveitis specialists, but at least in terms of retinal specialists. And actually, they asked the question 2017 and 2019, whether people have access to OCTA devices. And you can see here that the numbers from 2017 and 2019 have significantly increased. So the not vast majority, but definitely majority of people have access to OCTA. Interestingly, in the United States, the prevalence of the accessibility of OCTA is lowest when you compare it to Europe or Central and South America. But in 2019, they also asked the question whether they have access, but they don't find it useful. And at least around 19 to 20% said that they have access to it, but they do not find it useful. And I mean, there may be several reasons for this. One is, of course, you have to use the device to see its practicability and its usability in your daily clinic. Because if you don't use it and you don't know what you are seeing, it's definitely not useful, and definitely it just adds up in terms of time. So what about OCTA in uveitis? In OCTA definitely helps you to differentiate inflammatory CNV from inflammatory lesions. So it can do this even if intraretinal or subretinal fluid may not be present on OCT, despite there is activity. And very often it's superior to fluorescein angiography because it can identify more inflammatory CNV lesion than an FA is capable of doing. In particular, if you have a type 1 lesion in inflammatory due to inflammatory CNV, it is easier to be catched up and to be identified as a lesion as such in OCTA than on fluorescein angiography. This is just an example from my clinic I would like to share with you. This patient had recurrent CNV infections after a kidney transplant, and fortunately the donor was positive with a CNV resistant mutation, and so the recipient got CNV infections. But when you look closely, you see that despite the retinitis lesions and the hemorrhages, you can also see chororetinal lesions within the posterior pole in this patient. So when we closer looked, of course, we ruled out any tuberculosis or any atypical mycobacteria or any other underlying causes. And we found that the patient had multifocal choroiditis and secondary CNV and in a recurrent CNV retinitis. And when you now look very closely, so on top you see the right eye, on the bottom the left eye, you can see that in the right eye, the fluorescein angiography identifies two lesions, at least two lesions being present here. And when you then do the OCTA, you actually see that only one lesion really is a secondary CNV, while the other lesion is just an inflammatory lesion being present here. In the left eye, the findings of the early and late FA corresponds to the finding of the OCTA, where you can definitely identify the secondary inflammatory CNV being present. So the patient was started on treatment, anti-VEGF treatment in the left eye, and then two months later, we saw that the patient also developed active CNV in the right eye. And now what you can see here is when you compare it to the baseline visit, that the patient had shown a growth, a CNV growth here, and due to that also an activity of the CNV. So the patient was also started on intravitreal treatments on the right eye. This is then how it looked like after several treatments, and of course under ganciclovir and under intravitreal foscarnet, and the retinitis was stable as well. Another case I would like to share with you in order to convince you that OCTA is usable, and here in many cases superior to fluorescein angiography and ICG, is in a case with a corticosteroid-induced central serous in lupus erythematodes. So this is how the fundus pictures, the color fundus pictures look like in this case. And when you look at the OCT, you can see the sliver of subretinal fluid and also this subretinal hyperreflective material here in the right eye. Similarly, and even worse in the left eye, intraretinal fluid and a lot of subretinal hyperreflective material. Actually, when you look at the FA and the ICG, you cannot really tell whether there is really a secondary CNV being present in this patient or not. But when you perform then an OCTA, you can see this is actually really only fibrous reaction in chronic central serous in a patient with lupus, but there is no secondary CNV present in the right eye, and this is also true for the left eye. So the patient was not starting on anti-VEGF treatment. He was only the steroid treatment, which was installed because of the lupus, was tapered and stopped. And here you can see then afterwards the improvement where the subretinal fluid has completely resolved. And also here, the amount of intraretinal fluid and also the amount of subretinal hyperreflective materials had decreased in size. So in this time, it really helped you to identify and to give the correct treatment and avoid additional treatment maybe of anti-VEGF treatment, which may not have been useful or helpful here. So like I said, it can help you to identify more inflammatory lesion or more inflammatory CNVs than a fluorescein angiography can. And actually the majority of multifocal choroiditis or PIC lesions present flow, which is consistent with CNV. It also, like I've shown you, allows you the visualization of the detailed vascular structures and the therapy. And it also allows you a quantitative analysis of the CNV, which is usually not possible with with routine angiography. OCTA can be also very, very useful and help you to really precisely assess the disease activity and progression in chronic posterior and panuveitis. This is a patient with virtual chororetinopathy, a very characteristic presentation. And when you look at the ICG, you see the multiple hypofluorescent lesions. When you then compare it to the findings of the wide field swept-source OCTA, you can see in the wide field swept-source OCTA in the choroidal slabs that there are flow attenuation, which are corresponding to the hypofluorescent lesions on ICG. But what you can see here in the OCTA, but it's not visible on the ICG, is actually that the choroid capillaris is still spared. So you can already tell that the patient, well, although he has virtual chororetinopathy, this disease has not very far progressed so far. Then, of course, what it also helps, we started the patient we started the patient with oral steroids, and then 3 months thereafter under steroids, you see that some of the areas of flow attenuation have completely resolved. So you can see here now the lesions which are still left may be really due to real flow void. And now actually the areas which showed flow attenuation in the beginning may have been due to blockage due to inflammatory cells, but these have decreased. So you definitely could follow the treatment response in this patient. And what we do now, especially in this case, but also in all of the virtual cases, we use wide field swept-source OCTA to follow disease progression and treatment efficacy in these patients, together with full field ERGs and with gold-bound perimetry. It also helps you in other diseases where you have granulomatoous involvement of the choroid and the choroid capillaries. Also, for example, here in patients with VKH or VKH-like presentations, where you see in the beginning the flow attenuation due to the granulomatous lesions, and then you can follow the treatment response and the treatment success by doing by repeating the swept source OCTA images. And of course, you can also follow these patients regularly with this device and assessing whether the patient may be under treatment and needs additional treatment. Another benefit is that you can really quantify choroidal lesions here, and you can really compare the lesion size with previous visits,
Mariam,
with the current visits. Yes?
Which slide are you on? We're seeing slide 23.
You're right. Thank you very much. It didn't jump. So this was the slide I was presenting to you on granulomatous choroidal and choroid capillaris infiltration. And here you can see that you can also quantify these posterior lesions occupying the choroid capillaris and choroid, and this also helps you to quantify a potential progression of these lesions in the patients with posterior uveitis. There was also a paper which actually showed that you can automatically quantify these lesions and also quantify potential progression by using OCTA and swept source choroid capillary slabs. So you can see here that with OCTA, you have the possibility to individually assess the choroidal layers. It adds additional information, and you can also frequently follow up the patients, which you will probably not do with ICG, and you can also quantify the assessment. Of course, the downside is that any changes you want to capture beyond the central 90-degree will be hard to capture and will be hard to assess. And here you still need ICG and other angiographic possibilities and devices to assess these lesions. So the second question is, what about leakage assessment? What about the assessment of vascular leakage in larger vessels? And what about the assessment of peripheral vascular leakage? So I think we all agree that there's no direct assessment of leakage possible in OCTA, and Alessandra has already kind of touched on this topic. But the question is, are there any indirect signs of leakage using OCTA by quantifying central OCTA scans? The answer is you will find a decreased vessel density and decreased vessel perfusion in these patients. However, it's really not very sensitive in telling you whether the patient is active or inactive, or whether the patient has severe uveitis or not so severe uveitis. And also you have a lot of confounding factors. One of them is if the patient has severe inflammation, you will automatically have a lower value, a lower quantitative value. If the patient has cataract, the values will be wrongly lower. And of course, you have other confounding factors such like cystic macular edema and aberrant membrane. So in terms of this, it's definitely not a very valuable assessment tool. And you also have no threshold value, whether to tell you whether the patient has uveitis or has active disease or not. Another indirect sign of leakage on OCTA is if you kind of image an inflamed and leaking vessels with OCTA, you will see areas of low attenuation associated with the leakage being present here. However, here also it's, I think, not very convenient in daily clinic to really assess the individual vasculature using different OCTA images. So in terms of this, I think also fluorescein angiography is much more sensitive and it's a much more reliable tool than looking for indirect leakage assessments on OCTA. In addition on this is when you assess the arteries, the large arteries, you will always find flow void or an area of no flow surrounding the arteries. This is usual and this is normal, and this also allows you to differentiate an artery from a vein using OCTA. Another indirect or direct way to assess leakage, at least in larger vessel, is by assessing the retinal thickness maps. And here, of course, Swepsos OCTA is beneficial because it's much faster in the processing and in the image acquisition, so you can image a larger area. And if you have significant leakage being present in the vessel, you will see this also as perivascular thickening on the OCT thickness maps. And then, of course, if you see this on the OCT thickness maps, you can use it and you can follow the patient and you can look at the treatment response being here. However, again, the caveat here is you can only use it really for larger vessels because you won't see it for smaller vessels. And of course, only if you really have significant leakage being present. So if you have only a little bit of, for example, phlebitis being present, you will definitely not be able to assess it. And of course, when we talk about peripheral vascular leakage, there is actually so far no way to really reliably assess it using Swepsos OCTA. So in summary, it's definitely a valuable additional tool to monitor disease activity and diseases in uveitis. It's nice to differentiate inflammatory CNV from inflammatory lesion even better than fluorescein angiography can. In addition, and on top it's better to evaluate the lesion depth and the disease progression when you compare it, for example, to ICG. And it also allows an automatic identification and quantification of inflammatory lesions. But overall, it definitely does not replace angiographic techniques, at least not for now. Thank you.
Thank you very much, Marion. Well, that is a good introduction for the next talk, because now we're going to talk about indocyanine green angiography and other modalities to assess the choroid, the incredible Hulk, and Esther Carreño is going to guide us through this. Thank you, Esther.
Perfect. Okay, so now Marion has already done a beautiful job trying to convince that still we need fluorescein angiography and ICG, but I'm just going to try to keep on convincing you. So I think it's very important, and this is an imaging just to convince you again that we need ICG in uveitis, and you can see this imaging in the left, that is a fluorescein angiography, and then when you see the ICG in the left, you can see all these dark dots that were not very visible in the picture in the left. This is a case of an AMPI in the periphery. But to start with, I'm just going to do a brief reminder of what fluorescein and ICG are. So the difference between fluorescein and ICG is a higher weight molecular and also joins lipoproteins, and then that means that doesn't go into the retinal vessels and sticks into the choroid, and then it's better to see the choroidal circulation. It's also the fluorescein angiography absorbs the light in the blue spectrum versus the ICG in the red spectrum. So it means that when we do a blue autofluorescent, we are using the same thing as we used to do fluorescein, and we are using an infrared autofluorescent to see ICG dye. And every time that we have a dye, we can see something for blockage or something because there is a hyperfluorescent with leakage or staining. So for example, here we have a patient, and I think Marion has already showed this beautifully. Here, well, not this, sorry. Here we can see, if we get close, we can see some vessels in the disc. And even if we do in this patient, I don't have an OCTA, but probably an OCTA will be quite normal. However, if we do a fluorescein angiography, we can see that these new vessels are made because of the vasculitis that is going on in this eye. And also we can see the macular edema that we could already see with an OCT. And also has Marion showed that we can see very beautifully the ischemia, the retinal ischemia in an OCTA, but even is very similar, and we can see better the capillary vascularity in the OCTA. However, when we see these two patients, there is a small tiny difference between these two that we are not going to see in the OCTA, and this is this tiny leakage in the picture on the right. And again, with OCTA, we are only going to see the center of the eye. And in this case, we will completely forget about this in the periphery, that we can see that there is some ischemia going on and some beautiful new vessels starting to grow. And again, the same thing with the fluorescein angiography. We can see the imaging in the center. And then when we take a look to the periphery, we can see all the exclusive vasculitis and these new vessels going on. And that is also very helpful to target our laser treatment to try to prevent these new vessels to grow. And also we have now the opportunity to have ultra wide field ICG. And this is the picture of the same patient. And this is actually the left eye of the same patient that you can see that has a completely different picture with these choroidal lesions especially in the nasal area. And we can see again in the fluorescein angiography this occlusive vasculitis in the periphery, maybe not as visible as in the other eye, but we can see in the ICG how she has these choroidal lesions in the whole eye and not only in the posterior pole. And then I'm going to show you 3 patients that they came to the clinic with exactly the same complaint, more or less the same OCT, and how ICG and fluorescein angiography is fundamental in these cases to make a diagnosis. So we have patient 1, 2, and 3, which are all of them, let's say 40 years old male, and all of them are coming complaining of blurry vision in both eyes and a very heavy headache. So we go for the patient 1. So the patient 1, you can see maybe in the color fundus. I'm sorry, I don't have better color fundus, but you can see that there is some creamy yellow lesions. Maybe the vessels are a little bit tortuous, but nothing else going on. And then when you can see the OCT, you have this papillary retinal detachment that now is a little bit on fashion, I will say. And I don't know what is your first diagnosis that comes into your mind, but the first diagnosis that came into the mind of the person who saw this patient first was VKH, because you have subretinal fluid and headaches, so it could be a VKH. But then when you do the fluorescein angiography, that gives you completely a different diagnosis, because you can see in the early frames of the fluorescein angiography these hypofluorescent lesions that later on became hyperautofluorescent, and in the ICG these hypofluorescent lesions that remain hypofluorescent. So this is a completely classical AMPI fluorescent angiography and ICG. So this was a patient with AMPI. which stands for acute posterior multifocal pigment placoid epithelopathy. And this is another patient with AMPI, just to show you some more beautiful images with the same fluorescent angiography and ICG findings. And I think it's especially interesting that in the periphery, they have a lot of more lesions than you will expect, and we don't see that lesions usually clinically. And if you see with the OCTA, you can actually see exactly the same thing, which is actually like a mirror imaging. And ICG, I think OCTA is even better to monitor the progression of this disease because it's easier just to make in the clinic. And you can see in this case how the ICG, the OCTA at the level of the choriocapillaris shows this ischemia that is getting perfused with the time again. But the more interesting thing is actually with OCTA and ICG, you can detect lesions before they have a repercussion in the OCT, which is probably giving us the confirmation that this disease is probably a choroiditis rather than an epitheliitis, as the name says. So you can see the lesion that is surrounded with a red cycle, and that is visible in the early frames of the fluorescent angiography. You can see that this appears in the late frames, because it doesn't have an OCT repercussion that you can see in the imaging G1 and G2, that the OCT is completely normal at that point. And also you can see in the ICG how the lesion is hypofluorescent. And then in the OCTA, you can see how this lesion is also visible. With the time, with the treatment, it completely disappears. And you can also see that in the end phase OCT at the level of the choriocapillaris, there is not an hyporeflectivity that it will result from the affection of the RPE and retina. And here is another imaging of a patient with AMPI. And you can see how the lesion in the OCT is smaller than in the structural OCT is smaller than the lesion in the OCTA, which also gives us an idea that the primary insult is probably in the choriocapillaris rather than in the pigment epithelium. Let's come back to our 3 patients, and now we are going to go for patient 2. So patient 2 again has some creamy yellow lesions in the back of the eye, and we can see a horrible bacillary detachment in both eyes, and maybe not many choroidal folds, but a little bit. And when we do the fluorescent angiography, you can see that there is not much going on in the fluorescein and ICG. So the optic nerve is completely quiet. There is no leakage in the optic nerve, and there is no real leakage even in the late frames of the fluorescent angiography. So the one in the down are like 5 minutes fluorescent angiography, and still we cannot see any significant leakage. So this is a case of posterior scleritis. And again, we go for patient 3, which is probably the one we will not have to say if it's a BKH, but this one, when we do the fluorescent angiography and ICG, this is actually the real BKH. And you can see the leakage at the level of the nerve and with the pinpoint pattern that we see in BKH patients. And also CTA can help us a little bit, because in the BKH patients, we usually see these dots in the choriocapillaris, but it's also very difficult to segment because of the choroidal folds. And also fluorescent angiography and ICG can help us to diagnose something that is probably not uveitis. So this patient was referred to us with a working diagnosis of toxoplasmosis. And you can see only with the OCT that he had a little bit of retinal fluid, and the lesion was mainly subretinal with this very hyperreflective material before the pigment epithelium. So this is not a normal OCT for toxoplasmosis, and when you do an OCT, an ICG and a FFA, you will have the diagnosis, and you can see beautifully this smoke pattern, which is a classical of central serous retinopathy. And also, I just want to show us this work we did when I was back in Bristol with Colin Chu. We were trying we know that ICG is eaten by the granulocytes, and we were trying to imagine the granulocytes in the eye, and actually we couldn't find many cell-like lesions, but what we could find is like ICG also is eaten by the RPE cells. And this is a patient with early AMD. And you can see in the fundus autofluorescent, which is imagined on the left, that the fundus autofluorescent doesn't really show any really definitive dark autofluorescence. So it's just a mild hypoautofluorescent that means some damage in the RPE, but not really something similar to geographic atrophy yet. However, when we do the ICG and then we take a picture with the infrared autofluorescent or the ICG module of the spectralis, 24 hours later after administering the ICG, we can see that there is some areas of the RPE that are not eating the ICG the same as the other, and this is probably an early marker of RPE damage. And I think that will be something very useful in the future that we can use also with the dye. I think it's a very short talk, but I'm also very happy to get more things in the discussion. And just to remember my three patients with very similar presentations, which are 3 different complete things, and you can have this diagnosis thank you to the dye. So thank you very much for your attention.
Well, this was a very inspiring talk. I think you both agree that, we're not going to dispel the use of angiography, but you've both more or less shown cases where OCTA was very useful. So maybe Esther, since you were arguing for doing angiography, are there cases where you would just use an OCTA? What kind of diagnosis would you go directly to OCTA and not use angiography?
Well, I mean, I think it's very, very, very useful in AMPI. So I'm really, I think for me, it has completely changed the management of AMPI. I think ICE is still important because I think it's important mainly in the diagnosis moment, because it's very useful for having a better picture of what is going on in the whole retina. But I think it's very, it's the key in the follow-up, because you are not going to be ICG in the patient so often, but you can do an OCT every time that he comes to the clinic. So I think that's where I will definitely go for the OCTA.
So in most cases, you would get an angiogram at the very beginning, fluorescein and ICG, and then follow with the OCTA if the OCTA shows very specific lesions that can't correspond to what you saw, which I think is a nice approach. Mute is another one where I find OCTA useful because it does show a very nice pattern, as does autofluorescence. Marion, maybe the same question. So you've tried to convince us that OCTA is the way to the future and that there might be certain things that we can even identify in a multimodal approach. Where do you get, and do you feel that doing angiography is important? Marion, are you there?
I think Marion is busy answering the questions.
I see, okay.
The answers. Marion, are you there?
I think maybe she was expecting that my talk was going to be longer, sorry.
No, that's okay. I think, we will have to move on anyway because we don't have that much time left. But I think, what Marion brought out, which I thought was very interesting, is the fact that if we start looking at many other modalities, we may be able to see areas where there is leakage without seeing it. Although I would say one thing about saying that there are gaps in vasculature. OCTA measures essentially horizontally a Doppler effect, and it doesn't mean there is no circulation. It's just sluggish under what is able to be detected in whatever system we're using. And what I'm hoping is that as the SWEP sources get better, we'll be able to see a difference in the density of tissue over time. Maybe we can come back to Marion a little bit later. And then I think what we should do, just for the question of time, is just move on to the next talk. And this maybe goes on from what you've just said, Esther, because you're bringing up the importance of OCT. So old but gold is the next major topic. And Alessandro is going to tell us about how the last Boy Scout is OCT and is the Swiss Army knife of uveitis specialists. Alessandro?
Yes, thank you. So here we go. So OCT is actually the true Swiss knife for the uveitis specialist. In fact, we have been using OCT in uveitis to assess cystoid macular edema for a while, and I think it's probably the best technique to do that. And we keep using it for cystoid macular edema. But we have seen a massive increase in the number of papers published on OCT in uveitis in the last few years. And this tells us that OCT has many, many more applications than just detecting and monitoring the CME. And, you know, these are the main 3 points I see it applied in the clinic. We have already talked about the inflammation grading, so I'm not going to touch that point, but we will focus on the differential diagnosis and the management and response to treatment. So starting off with the differential diagnosis, I think one of the most important things that OCT provides us with is the depth of the lesion. So if we look at these 4 images, we see, you know, like yellowish, creamy lesions at the back of the eye. They look very similar to each other. Of course, we can understand whether you know, the retina is involved, at least the inner retina, looking at the vessels. So, for example, up here in the up left and in the lower left image, we see that the vessels are on top of the yellowish lesion. So it has to be you know, somehow deeper than the vessels, but we can't really say whether these lesions are affecting the RPE, just the outer retina, the choroid. And in this case, OCT is definitely helping us. So my suggestion is to perform an OCT scan across all the lesions. We are not really able to, you know, clearly understand. And of course, this is going to help us. And this just to show you in these 4 different cases. The first one on top left, we see that all the lesion is actually affecting the retina. So we've got a full thickness retinitis, and the RPE is spared, and the choroid looks normal in thickness, and just a bit of shadowing from the overlying retinitis. Up here in the top right corner of the slide, you see that everything is basically in the vitreous. So we have that this lesion is probably just you know, vitreous clots on top of the retinal vessels, while here in the left bottom left corner, we see that we've got like a bacillary detachment, we've got retinitis, we've got fluid, and we also have focal choroidal thickening with disruption of the choroid underneath the retinal lesion. And finally, here we see that the RPE in the top, in the bottom right corner, you see that the RPE is disrupted, and we've got the lesion growing from the choroid, getting into the subretinal space and pushing up the retina. So basically, the OCT is telling us which components, which layers of the retina, the choroid, the RPE are involved, and this is definitely helping us in the differential diagnosis. And in fact, the first patient is affected by Behçet, which can give us retinitis, but definitely doesn't affect the choroid. And in fact, the OCT is showing us RPE and choroidal sparing. The second patient is a patient with sarcoid and with prevalent perivascular involvement. The third patient is affected by toxo, which we know gives us choroidal and retinal involvement. And the last one is a patient with endogenous candida endophthalmitis. And here the fungi are growing from the choroid through the RPE underneath the retina, and they are heading towards the vitreous cavity. And of course, we can use these hints given by the technique to try to differentiate between different etiologies that look similar to each other. Like in this case, we've got a patient with a toxo in HIV and a patient with acute retinal necrosis from VZV. If we compare the OCT of these 2 entities, and if we compare the OCT with the histology, you can see that they look pretty similar. So in viral retinitis, we've got a choroidal sparing, while the RPE and the retina are affected. While in toxo, for example, you definitely have an involvement of the retina, full thickness retinitis. You may have involvement of the RPE, but what makes the difference is that the choroid often, very often, looks involved, and it has a disruption with a granulomatous infiltration of the stroma. So if you compare the OCTs between toxo and viral retinitis, they look very similar because the retina may seem similar to each other. Sorry, they look very different because the retina and the retinitis may have similar features, but the choroid is definitely different. In toxo, you've got choroidal disruption and focal thickening, while in viral, you don't have it. And also the vitreous may show some differences. For example, in toxo, these oval deposits on top of the retina and in the posterior hyaloid have been described and seem to be much more present compared to what you see in viral retinitis. So this is just an example, a practical example of how these criteria can be helpful in the differential diagnosis. Here's a patient with this massive retinal necrosis and performing the OCT. This is a peripheral OCT. This is why the quality is bad. The patient had vitreitis, and but you can still see that there is full retinal thickness, retinitis, full retinal disruption. But underneath the retina, you see a focal thickening and a disruption of the choroid as well. And on top of the retina, you can see one of those oval deposits. So all these three signs are pointing us towards toxoplasmosis. Even if the clinical picture could seem that of an ARN. And in fact, we performed a tap and inject, and we found out that the toxo was positive. We remember that viral sensitivity is around 90, while toxo sensitivity is around 50 to 60. So it's a toxo, and it's atypical, of course, in the appearance. But we can say that definitely the OCT was already pointing us towards the correct diagnosis. So the CMV retinitis in particular can affect the retina following two different patterns, and it can come from the choroid, but even if it comes from the choroid usually doesn't look increased in thickness, and there is no disruption of the choroid itself. The only difference is that the RPE is going to be involved, so you see this sort of melting, while if you don't have RPE involvement, you see this sort of lacunae, and it's more likely to develop a retinal detachment. So sorry for the slides, they are not following me. Okay, so another important feature that OCT can assess in the choroid is the presence of choroidal granulomas. And if you look at this comparison between OCT, EDI OCT, and histology, you can see that the granuloma look very similar. Now, we all have been assessing patients with chronic CSR, and we know that choroidal vessels can seem similar to choroidal granulomas in the ADI OCT. So how do we distinguish between the two of them? And once again, we don't need ICG. We can just perform an OCT EDI here, because when we look underneath what it could be a lesion or a vessel, you see that all the vessels are creating a shadowing underneath on the underlying sclera, while granulomas usually have an increased transmission effect. And this is due to the interaction between the OCT signal and the lesion itself. And of course, if you want to be sure, you want to perform an ICG, but you can see that here the ICG is showing that the granuloma is hypofluorescent, and on ADI, we've got the increased transmission, while the dilated vessel is hyper in ICG, and it doesn't have any background signal on OCT EDI. Now, of course, in the interest of time, I'm not touching all the clinical entities we can come across, but OCT has specific features in different entities. For example, we've got these sort of let's say increased reflectivity of the vitreous on top of the lesions in CMV retinitis. We have already talked about these deposits in toxo. Candida often has this massive shadowing underneath the lesion sitting on top of the retina. While if we move a bit towards the external retina, we've got very typical features in placoid syphilis, nudes, MFC, and VKH, of course, with its massive thickening and diffuse thickening of the choroid, in contrast to toxo, which has the focal thickening. And this is AMPI with these outer retinal lesions and focal thickening of the chorocapillaris. So as I said, I cannot go through all the uveitis and their features on OCT, but you can find everything in this beautiful review that Francesco, Marian, and I co-authored, and where you find all the list of non-infectious and infectious uveitis and the OCT features. Now let's move to follow-up and response to treatment. Well, I think one of the first diseases where OCT was used for the follow-up is VKH, as we know that EDI is able to assess the choroidal thickness, and VKH is characterized by a massive choroidal thickening when the disease is active, and this precedes the accumulation of subretinal fluid, and then when the disease is quiet, the choroid gets thinner again. But of course, choroidal thickening can be used to assess the inflammation in several different uveitis. This is a patient with tubercular uveitis, and you see that the uveitis was active in the B-scan on top, and then when it resolved, the choroid got much thinner. So my suggestion is, if you have the EDI OCT, then perform it to all your patients, because it has been described that choroidal thickness can vary even in anterior uveitis according to the inflammation inside the eye. Of course, you can also follow choroidal lesion, like in this case, choroidal granuloma in ICG seems very similar from baseline to follow-up. The same is at fundus photos, but OCT is showing us that the lesion is regressing after treatment. And the reason is that OCT provides us with anterior, vertical diameter information, while the other techniques gives us the horizontal extent of the lesion. And the lesion tends to regress first along its vertical diameter and later on along its horizontal one. This is just another example of tuberculoma followed with OCT. You see that OCT is telling us whether the fovea is attached or not, and then it's showing us the resolution of the lesion. And one last example, this is a patient with the endogenous Candida endophthalmitis. We started the treatment after day 1, and 2 days later, the patient came in with an hypopyon. So we were scared that we had, done the wrong diagnosis and the patient was actually getting worse. But OCT told us that the lesion was actually regressing. So the hypopyon was likely an Irish excimer reaction to the beginning of the treatment and the death of several fungi. So OCT is actually helping also in following the lesions and understanding whether the patient is responding to treatment, even in atypical cases. So to conclude, OCT is obviously commonly assessed commonly used to assess the presence of cystoid macular edema and common complications like epiretinal membranes and others. But we have several other applications of OCT in uveitis, and this is why it is the Swiss knife of the uveitis specialist. And of course, it can help you in your clinical practice from the diagnosis to the follow-up. And I thank you for your attention.
Thank you very much. These are fantastic pictures. You either are very good at taking pictures in some of these difficult cases, but with such bad vitreous, being able to image the retina as well as you did is impressive, I have to say. We'll come back to our questions after. Now we have face-off, en face OCT to assess the outer retinal changes in uveitis, and Francesco is going to tell us all about this. Francesco?
Thank you very much. So thank you very much for the invitation. Let me know if you can see my slides. I guess you can. So these are my financial disclosure, first of all, and I'm gonna start with a case. This is a 19-year-old female that's been complaining for 6 months for scotoma in the left eye. She comes for a second opinion, and in this left eye, she's 20/20, but she's missing a couple of letters here. Now, this is the fundus appearance. You can see there is an area of the pigmentation around the disc, and you can see multiple small areas of changes in the periphery. Now, let's look at the OCT over these areas. You see that there are areas where the ellipsoid zone is missing, not only at the level of the fovea, but also in the mid-periphery. And in some areas as well, the loss of the ellipsoid zone is so dramatic that the outer nuclear layer is falling down as well. So at this point, how to diagnose and follow this young girl? Well, autofluorescence comes to mind first because the ellipsoid zone is gone and it's unmasking the underlying RP autofluorescence. So FAF could be a great idea. Now, what about dye imaging? Well, it's not showing a lot in this case. But we have a secret weapon, which is en face OCT. Now, this is a wide field en face OCT at the level of the ellipsoid zone, which is showing very, very well all the changes that we've described with OCT. And you see where the outer nuclear layer is more preserved, we have an area of hyperreflectivity in the center, but otherwise there's much hyporeflectivity. And looking at since we have OCTA, we looked at the OCTA and it's not showing anything in this lady. So the diagnostic hypothesis is Azor/Anor spectrum. It was mute in the beginning, but the RP would have been more involved, and she was not improving with steroids. But that's not the point. So the point is, for those of you that know the movie Face Off, we were all fascinated by John Travolta, by the bad character, as we are all fascinated by OCTA. But sometimes we forgot that there's another side of the medal, which is en face OCT. And en face OCT is something that we all, most of us have in our clinic, because when we do a raster of OCT scan, you basically create a cube. And then when you have a cube, you have the ability to look what's on top of the cube and to slice the cube at different levels and get an en face OCT. So how en face OCT has helped us in the past? Well, it has helped us gain insight into different pathologies like mutes and AMPI. For example, in mutes, at the time when I think it was 2014, when Januzzi started talking about spots and dots in mutes, looking at dye tests like FA and ICG. Well, we did a study using en face OCT, and we showed that these spots are very visible on the en face OCT at the level of the ellipsoid. You can see them, they're hyperreflective and they're very, very visible. And if you move the slice of the en face OCT just a bit towards the vitreous and you slice at the level of the outer nuclear layer, you're able to see the spots. These spots are now hyper-reflective. So with no use of dye, we're able to see dots and spots in mutes. Now, what are these dots? The spots first, sorry. What are these spots? Now, these spots correspond to an ellipsoid disarray and an RP hypertrophy that's very common in mutes. You see there's an increase, a slight increase in the autofluorescence corresponding to the spot because the RP is reactive and there are less ellipsoid zone. And this is not only in the center, you can see it along the vascular arcades as well. Here, the ellipsoid are disrupted and you can see an increase in autofluorescence. And moving on now from the spots to the dots, same patient. We just scan with the en face a bit up towards the outer nuclear layer, and you see these hyperreflective dots that corresponds to dots in the outer nuclear layer. There are a couple of hypotheses. This can be either nuclei of the photoreceptor which are suffering, or Muller cells. We don't know, but there are dots indeed. And these dots are not, you cannot catch them in autofluorescence, and you can find them as well in the periphery with the UNFAS OCT. UNFAS OCT at the time was able to tell us that the lesion that we see in nudes in ICG and are hypofluorescent, they actually correspond very well to the spots that we see in UNFAS. So that was the first hint that the choroid was probably not affected in nudes. So UNFAS was paramount here. But moving on to another controversial disease at the time, it was AMPI. During history, there was a couple of hypotheses where AMPI is coming from. Does it come from the retina, from the RPE, from the choroid, from the choroicapillaris? Well, you're all familiar with the picture of AMPI, and Esther showed beautiful pictures with ICG, and has shown this creamy lesion as well. Well, we conducted a study together with the UCLA and PGI as well, and we combined both OCTA and UNFAS to get a better understanding of AMPI and the pathophysiology. Now, Esther has shown this already. This ICG hypofluorescent that you see is a real ischemia. And it corresponds to area of no signal from OCTA at this level. So OCTA, as Esther was saying, can be used in such cases. But when you do an OCTA, by default, next to it, you have an UNFAS OCT, so use it. Now, you see this patient, the areas of no flow in the choroicapillaris correspond to areas of ellipsoid and disarray and RPE changes. And you see they correspond very, very well. And when you treat the patient, the ischemia decreases, but and at the same time, the RPE goes back to normal. And after 2 weeks of oral steroid, the RPE in UNFAS and the ellipsoid are nearly completely back to normal. So this, we don't know which is the primary starter, but we know the choroicapillaris is hyperperfused and it's causing RPE atrophy and some retinal lesion in AMPI. Now, UNFAS has been paramount in these two diseases, for example, to understand the pathogenesis, but you can also use it in your normal clinic. This is a patient that came recently with Rift Valley fever retinitis. And yes, we did FA, we did ICG, we did a lot of stuff, but look at the UNFAS picture. It's telling us a lot. First of all, it's telling us that one of the main reasons why this patient's vision is compromised is actually a loss of the RNFL, which is very typical in Rift Valley fever retinitis. It's affecting also the optic nerve, it's causing optic neuritis. And you see all these gray areas, they are the areas of retinitis. Now, let's look at the scan as a slice of UNFAS at the level of the outer retina. You see, this area is hyper reflective, but it's slightly different from this one. And we were able to see that there are just two different stages of outer retinitis. Here, where it's more hyper reflective, you see the retinitis is nearly healed. The RP is mottled, and the outer retina has basically disappeared. And in this area where there's less hyperreflectivity, well, you see the RP is still intact, and there is edema of the outer retina, which is an active area of retinitis. Other examples, a case of GCA with choroidal ischemia. Now, the eye test here is paramount, and OCTA of the choroicapillaris is telling us something, but not a lot. But look how beautifully UNFAS it's reflecting the wedge-shaped area of ischemia. And finally, a case of APVM. You see, it was caused, I think it was secondary by a melanoma in this case. You see the typical OCT appearance, but at the same time, you see all these changes reflected at different layers of the retina that we can study with the UNFAS OCT, and we can follow with the UNFAS OCT. And with this, I thank you very much for your attention.
Thank you very much, Francesco. I think you very nicely shown with these images the importance of doing these UNFAS images and being able to look at them both by using autofluorescence as well as other modalities. We have a few minutes, so we might as well look at a few questions with regards to these last two presentations. Are there situations, maybe you can give us a little bit more, you've mentioned the use of the autofluorescence, and you've also looked at OCTA. Do you think, when is OCTA better in en face imaging, and when is, do you think, just the autofluorescence itself? Are there specific diagnoses where you would go for one or the other, or you would always look at both images?
So, you know, all of us here are a bit of imaging freaks, so we get a lot of images. But, you know, for example, the first case, the Azor, Anor, so that's not really a disease of the RPE. The autofluorescence is just an unmasking. So I was following that girl, and FAF was really not changing a lot because the photoreceptors are just unmasking the normal RPE underneath. So the RPE is normal. So in that case, I found UNFAS more useful. In other cases like MUDES, well, of course, FAF, I think it's one of the best images modality as well as OCT to follow up MUDES. So it really depends if the RP is affected or not, in my opinion.
Yeah, and maybe going to looking at it en face, you know, Alessandro, you mentioned how you can look at granulomas and follow them. I found that getting en face imaging inside the choroid is sometimes very useful because you're able to follow over time the variation inside the granulomas. Do you agree? Is this something that you do, or do you think that just looking at it in standard OCTs is the better way to proceed?
No, actually, I think we started doing OCTA of the choroid as well with the new OCTA devices is doable. And as Francesco was saying, every time you get an OCTA, you also get an en-face image. So you can actually pick up a lot of information from the en-face visualization and the OCTA of the choroid. So granulomas, for example, are visible. It's kind of tricky to distinguish between small granulomas and phlovoids on OCTA. But then OCTA, the en-face visualization definitely allows you to measure the diameters as we were looking before. The other thing that I think Francesco mentioned is that you combine more imaging modalities. And in fact, when you get an OCTA, you basically have 3 different images modalities. You've got OCTA, you've got the B-scan, and obviously it's important to look at the B-scan, especially because you can turn on and turn off in most devices the flow information. And that's, you know, it's very helpful in interpreting the OCTA image. And of course, you have to look at the en-face as well. For example, you may have lesions like PAM or conditions like PAM. So there you've got, you know, like an ischemia, but it's maybe a transitory impairment of the flow. And then on OCTA, you don't see much, but you can see beautifully the lesions looking at the reflectivity on en-face OCT. So it's really a matter of combining different imaging modalities.
So Alessandro, while we are at it, suppose you see PAM on OCT B scan, which it is so characteristic, and now our post-COVID patients, we are seeing so many of them with these asymptomatic PAM area when you are, would you really need something else other than B scan to confirm that it is PAM, or is it just for fun?
Well, I think, you know, with the B-scan, you've got an information about the lesion that the ischemia or, you know, the transitory flow impairment created, but you have no idea whether the flow has been restored, completely restored. So I would say that for, you know, to make a diagnosis of PAM, you probably just need the OCT, the standard OCT. But then you want to perform an OCTA or a fluorescein angiography to see, I would say an OCTA because it allows you to see all the plaques, you know, the deep one, the superficial one, to see whether, you know, the capillaries are still there and still working. So this is my personal call.
Thank you.
Thank you for the answer, for the question.
Then maybe, Any other questions from the panelists?
I think if I can just add something, because you mentioned, Mark, about the quality of the images. I think the only trick to get so good images is to play a lot with the, with the OCT device, because, for example, with vitreitis, you may ask the patient to look away and then look in another direction and then look back to the center. And, if you play around a lot, you can get much better images. And even the peripheral lesions, which seem to be, like unreachable most of the time, they are not so difficult to image. And, it's just a matter of having time to develop some skills and spend time on the patient you really want to image. That's the
So
only
do
thing.
you image yourself? Are you imaging yourself?
So not the,
Oh, sorry.
sorry. No, go ahead, Vishali.
No, there's a question for Francesco, but you complete the thing first.
Okay, so yeah, I do not perform standard imaging like, CME or, but when I have an interesting patient, I do the images myself. Yes.
Francesco,
Which I think is a good approach.
RP mapping, there is a question from the audience.
Yes.
Can RP cell mapping and density study be done? And can you do a video recording of NFAS study of RPE?
So I think Sunil in Cleveland, that he was working on automated RPE mapping and density study. I'm not sure currently that it can actually be done, but he's definitely working on it. So I can't really answer the question in more depth here.
Okay, thank you.
There was still maybe one more question. We've seen changes in multicolor imaging with corresponding off-fast and OCTA changes, AMN, in post-COVID-19 vaccination patients. Are there any thoughts from any of the panelists with regards to that? So I personally, we not just, but we published now 6 months ago, it got accepted recently on JAMA, a case series of post-COVID-19 vaccination side effects, and a couple had AMN. And in the JAMA paper, we did report on FAST and OCTA. Now, the problem in these cases is OCTA, you have to make sure you are segmenting the right layers of the retina, because you don't want to create artifacts. So while in clinic I use OCTA, I scroll through it and I use and I go. When you publish such things, then you have to be careful with the segmentation.
But just regarding the multicolor images, I think I like it a lot. Not only in terms of AMN images, because sometimes you can really visualize lesions easier than by just looking on it on color funders image themselves, for example, or on a fast image. And I think just AMN is just one example of it. So you can, because you have because you use different reflectance images, you have different layers or different layers you can really visualize only by looking at the individual layers. So for example, when you have green reflectance, you nicely show a subretinal involvement, like subretinal fibrosis and stuff like this. So if you have it, it's really useful. And to identify it. And also, if you train a machine learning algorithm with color funders images and then you kind of test it on multicolor images, it does pretty well. So sometimes it seems that it's even easier to assess something on multicolor images than on color funders, also for machines.
Very good. We'll go on to the last last topic, in fact, cutting edge imaging in uveitis. And the first speaker is Francesco again, and he's going to talk about Greece, imaging of the vitreous, to get some insight into uveitis. Francesco?
Thank you very much. So my financial disclosure have not changed. Now, while the vitreous is actually the biggest structure inside the eye, it was only in the 70s that there was an interest in it. Now, Worst used ink to visualize two main areas: the premacular bursa, which is an optically empty area before in front of the macula, the area Martegiani in front of the nerve, and various cistern. And in the same year, Eisner visualized some optically empty fissures in front of the vessels. In the 90s, Kishi visualized with OCT actually the premacular bursa. I just named it different, precortical vitreous pocket. But basically, there are various methods to visualize the vitreous. But imaging is difficult of the vitreous, because imaging in vivo, of course, because the vitreous is large, it's transparent, it's a moving tissue. So we really need something wide and 3D to image the vitreous. And we have it, after all, the ANFAS that I just spoke about, and swept source OCT. As you can see here, swept source OCT is not just useful for the choroid, but to visualize the vitreous as well. So we started with a working question. For those of you who are cataract surgeon, why are some patients predisposed to getting CME after uncomplicated phaco? For all of us that are uveitis specialists, why some patients with acute anterior uveitis develop CME and some don't when there is no posterior or intermediate involvement? Now, to try to understand this question, we use the swept source OCT. As you can see here, this is a large 16mm scan of the retina swept source. And if you increase the gain, you are able to visualize the vitreous better. And at the same time, we did the ANFAS cube I was talking about, but with the retina at the bottom of the picture. So we were able to better scan the vitreous. So we started by analyzing 45 healthy patients. And this is the ANFAS, the scan of the cube I showed you before in the at the level of the vitreous. And you can see very well the premacular bursa, and you can see very well the cloquet canal. There are empty spaces. In the corresponding B scan, you have the two same structures, and they're both separated by a septum, which is continuous. You see there is no communication between the two. If you do the vertical scan, you see the bursa has this particular appearance because it's called gravity. So the main gel, body of the gel goes down and the bursa is pushed up a bit. We saw that this appearance is quite characteristic in all healthy patients. It changes slightly with the decade. This is a couple of pictures from patients in the 20 and 30. You see the bursa, the cloquet canal, the separation. If you scan more towards the eye, these are the microns. You see that there are some cisterns that were described. But if you go to another decade now, the 30 to 40 decade, you see that the cistern actually increase in size, but the bursa and the cloquet canal, they are mostly still separated. And this is for you to understand how the vitreous actually degenerate, and we are able to pick it up with ANFAS OCT. Now, in the 45 healthy patient, we measured the diameters of the bursa and the cloquet canal. Here are the measurements, but that's not really important. What's important is that with the ANFAS swept source OCT, we were able to visualize both the bursa, the cloquet canal, and this separation, this gel separation between the two of them. But after all, we are here to talk about uveitis. So we enrolled also 90 patients with anterior uveitis. And here are a couple of examples. Now, this is a 17-year-old, and you see very well the bursa, you see very well the cloquet canal, but there's something missing. Now, here, there is no separation between the two of them. So there's a continuum. And if you look at the ANFAS, now there's a semilunar appearance of the bursa, which is connected to the cloquet canal. Another patient, same premacular bursa and same cloquet canal. And here there is a communication. Probably that was the septum, but it's not there anymore. And the two optically empty spaces are connected. And these are young patients, 17 and 21. So this is not a normal degeneration. This is not age-related vitreous degeneration. This is a video to show you how the two optically empty spaces of the bursa and the cloquet are connected at every level of the inside of the eye. Now, overall, we had 90 patients with anterior uveitis. The diameter of the bursa were slightly larger compared to the normal patients, but not the cloquet canal. And in the 90 eyes, we were able to detect the connection between the bursa and the cloquet canal in 87% of the patients with anterior uveitis. Now, of these patients, with anterior uveitis 37 presented at baseline with acute anterior uveitis and associated CME with no intermediate and no posterior involvement. This is 27% of our total cohort and 41% of the anterior uveitis group. And here is an example. This is a young patient with acute anterior uveitis and CME. You see the premacular bursa, you see the cloquet, you see there's this tiny bit of septum, but a huge communication between the two areas. So here we have, it's a bit tricky because if you scan, if you slice your anfas cake, at this level, there seems to be a septum, but if you slice at this level, there's no septum. There's just a big communication between the two optically empty spaces. So in the 37 eyes that presented with acute anterior uveitis and CME, the diameters were slightly larger, but what's important is 100% of these 37 eyes with anterior uveitis and CME had a communication between the bursa and the cloquet canal. So there was no septum present in none of the eyes who had CME. So the Vitreous, based on the studies done in cadaver eyes and in vivo with OCT, consists of a premacular bursa, optically empty space in front of the macula, a cloquet canal in front of the optic nerve, a hyaloid tract of Eisner, which comes from the regression of the hyaloid artery, and the Berger space. So our hypothesis is that when you have anterior uveitis and you have a communication between the bursa and the cloquet where the septum is gone, well, the cytokines from the anterior chamber have basically a huge highway to reach the macula, and this can be a contributing factor to the development of CME. This could also be a working theory for patients who do fake one complicated and then develop some degree of CME. So we published our results if you want to read the paper, but basically we're saying what I just said. So the vitreous gel is transversed by connecting channels from behind the lens to the macula. It is our hypothesis that one of the factors that predisposes patients with acute anterior uveitis to CME is when you have this communication between the premacular bursa and the cloquet canal, so that the cytokines can travel freely and faster towards the retina. This is of course, but it's tell you how imaging can help us understand better different pathologies. Thank you very much for your attention.
Again, these are beautiful images. You're going to have to tell me how far anterior you can image with an OCT. Years ago, I tried to do this with Heidelberg, and we couldn't get beyond I think about 300 microns. So it really was very limited to the posterior pole, but we'll come back to that. Now we're going the other way, I believe. We're going 6 feet deep and advanced imaging of the choroid in uveitis. And Annie Rudas Agarwal is going to tell us all about this. Annie?
Thank you very much for the introduction. Thank you very much, IUSG, for the opportunity. So I will be presenting on advanced imaging of the choroid in uveitis, and we're not really going 6 feet deep, but we are going 6 microns deep into the choroid here. Now, imaging of the choroid is not so easy, and we've heard in the previous talks, we often have to use indocyanine green angiography as well as OCTA. And often we realize that even the experts, they have no clue. So the key points of my talk would be challenges in the OCT analysis of the choroid, the automated quantification of choriocapillaries, OCTA in choroiditis, the relationship between the choriocapillaries and the outer retina, and the choroid in granulomas, and TB and sarcoid would feature in those. So why is the imaging of the choriocapillaries difficult? This is because we know that in choroiditis, we realize that there is a variability in the height of the choriocapillaries slab and the thickness. This is present even normally. The choriocapillary slab is not uniform, and this problem is accentuated in patients with uveitis. The other aspect we know is that patients with uveitis, specifically choroiditis, have an irregular RPE. Under this RPE, it's very difficult to visualize the choriocapillary. Sometimes there is a different reflectance pattern. You may have a hyperreflectivity under the RPE. The RPE itself may be having a different height or thickness. And this is why if you have patients in whom you want to quantify the choriocapillaries, there may be problems, especially if the device uses an RPE offset. Nonetheless, we have third-party software such as ImageJ available. And what we can do is use the NFAS OCT images and analyze them using ImageJ. And as you can see, run a macros. And once you run a macros, you can get a quantification of the choriocapillaries flow void areas. Now, there is another way to do the imaging of the choriocapillaries flow deficit and quantifying them using NFAS OCTA. So let's say you have this patient with an NFAS OCTA. You have the corresponding superficial capillary plexus. Now it's very important to subtract the superficial capillary plexus so that you avoid areas of projection artifact, and you take off these artifacts from this, and what you generate is, after using a certain threshold, a binarized image, and this can give you an automated choriocapillaries flow deficit area. So in our practice, obtaining this flow deficit area at baseline and follow-up is very important. For example, in this patient presented at baseline visit is panel A, and you can see this patient has TB, choroiditis, and he developed paradoxical worsening of the disease. And in panel D, you realize that there is worsening of the disease, the flow deficit has increased. But after binarizing the image, you can actually quantify the areas in the choriocapillaries flow deficit. So serial assessment of choriocapillaries flow deficit is possible in an accurate manner using thresholding algorithms. So the steps are simple. You standardize the image, you remove the projection of the superficial vessels, and you binarize the image. And now you have various autolocal thresholding algorithms, and one of the most commonly used is the Fansalkar's thresholding method. So it's very important for us to set the offset at the Brooks membrane to be minus 10.4 microns. That is the thickness of the choriocapillary slab that we take as standard in our patients. And this is the example of the ImageJ software having the Fansalkar's threshold. So just to reiterate that there are various challenges, this table just shows you three main challenges of quantifying the choroid. First, the choriocapillaries is not uniform throughout. And so one of the possible solutions is to use a manual segmentation with a minus 10.4 microns offset. The RPE may be irregular. So when you're doing your analysis, your algorithm should correct for the RPE, although it is not 100% not foolproof. The superficial plexus may cause projection. So it's very important to use PAR, which is projection artifact removal. There are two additional things. One is image compensation and averaging of multiple NFAS image to give you a better choriocapillaries assessment. Now, OCT in choroiditis is very useful because when the disease is active, it shows you that you have an involvement of the outer retinal layers. And when the disease heals, there is a knobbly elevation of the RPE. There is disruption of the inner and outer segments. And when the disease heals, you have atrophy of the outer retinal layers and the RPE. Now, this is a patient who has serpiginous choroiditis in the left eye. It's active, as you can see on the autofluorescence. The right eye has macula involving choroiditis, which is active because you have hyperautofluorescence. And this is the combined fluorescein ICG that we usually perform in these patients at baseline. And particularly on the ICG, you can see hypofluorescent areas in the macular center. This is a blown up image of the ICG, and you can see the NFAS OCT angiography shows you such beautiful delineation of the flow deficit areas. And because it compares very well with the ICG-A, you know that this is a true flow void. So in patients with SLC, the OCT angiography shows you choriocapillaritis, ischemia of the inner choroid, which corresponds to the ICG. These findings were published by our group in 2017, and subsequently we moved forward to following up these patients and obtaining the images at 3 months. And we can see that the indocyanine green at 3 months shows just a very minimum disturbance of the choriocapillaries in the center. This is the comparison of the ICG. And the OCT angiography shows you a very beautiful delineation of the choriocapillaries and shows you the exact areas where you have choriocapillaries atrophy. Now imagine if you do the semi-automated quantification, you will get a very good objective metric of the improvement in the choriocapillary's health. We observe that lesions less than 0.1 millimeter square on OCTA tend to resolve with minimal flow voids, and our findings were published in Retinal in 2021. And you can do a serial follow-up using OCT angiography in these patients. Now, why is the size of the choriocapillary's flow deficit important? It's important because when you have a smaller lesion, you have less choriocapillary's atrophy. Now, would early aggressive treatment really lead to less choriocapillary's atrophy? And now with this hypothesis, we published this, we performed this study, which is under review, where we did a clinical trial and categorized patients into two groups. We randomized them to receive oral therapy, and the other arm received intravitreal Ozurdex plus oral corticosteroid therapy in choroiditis. We realized that patients who received combination therapy had much better improvement in the flow deficit areas on OCT angiography. So the group 1 received standard treatment, the group 2 received intravitreal dexamethasone implant at baseline. Patients who received dexamethasone implant, they also had better improvement in the visual acuity at 12 weeks. I'm just going to show you one case where this is from Alex Fonoloza, who has this patient who came to him with a history of trauma in one eye, and you have sympathetic ophthalmia with serous retinal detachments in the other eye. And you can see that there is a serous detachments as usual we see in these patients, and this patient was treated like everyone else. We gave intravenous steroids. But what is important is that the outer nuclear layer is not hyporeflective in this patient. Instead, you see a hyperreflective band. So these are the normal layers of the retina where you should see a normally hyporeflective outer nuclear layer. But in this patient, you see a hyperreflective zone. You don't really see the outer nuclear layer. The importance of this is once the patient was treated, this patient developed atrophy of the choriocapillaries and RPEs subsequently. So does the outer retina have a role to play in the prognosis of the choriocapillaries recovery? So there may be an association between the reflectivity of the inner retinal layers and the choriocapillaries, and they may be associated with poor prognosis. Finally, I'd just like to conclude by showing you a couple of cases of TB and sarcoid choroidal granulomas. We all know that imaging of the choroidal granulomas is possible with EDI OCT, and this work was published by Alessandro here, 2016 and 17. And it's very useful to detect granulomas in sarcoid and TB. And we have also performed longitudinal follow-up of these choroidal granulomas. Again, these are beautiful images taken by Alessandro, where he shows reduction in the parameters, the dimensions of the granuloma on EDI OCT. This is a typical patient of TB choroiditis, and we realize that TB and sarcoid can be very different when you do imaging, especially OCT and fluorescein angiography. Patients of TB granulomas, they tend to be very large, they tend to be yellow, they tend to have a lot of vascularity on the surface, and they tend to have retinal angiomatous proliferation. These are typical for TB choroidal granulomas. And if you look at the OCT is so characteristic, where you have such a large choroidal granuloma sitting in the choroid, and you have fuzzy infiltration of the outer retinal layers. This outer retinal fuzziness of TB is very useful in distinguishing TB from sarcoidosis. And you see that this is a patient of sarcoidosis where you have multiple granulomas. You don't have a single large granuloma unlike TB. And in fact, TB, the sarcoid choroidal granulomas are usually small and very well localized to the choroid, and they do not involve the outer retina causing fuzziness. So with this, we can differentiate sarcoid choroidal granulomas. Of course, there is one case report of vascularized sarcoid granuloma published by Francesco. So of course, this is not confirmatory, but highly suggestive. And you have to depend on lab tests to rule out TB or sarcoid either ways. And this was published in AJO. So with this, I'd like to conclude my talk, and we'll be happy to take any questions. Thank you.
Thank you. This is a very nice talk and a difficult subject, imaging the choroid. I think one of the other things is if we have a bad interface at the RPE, since it's used essentially also to align all of the OCTA scans, we have to realize that the choroid fills and empties continually. So it adds to the complexity of getting a beautiful line. So maybe we need another point of reference if we want to do the alignment with A scans. One thing nobody's mentioned with the granulomas is that, at least when I look at sarcoid patients, I see a lot of hyperreflective dots that are present in the choroid and also in the retina. And I don't know if others would like to make a comment with regards to that, but when I look at inflammatory disease, I see these both in the retina as well as the choroid. Any comments from anybody of the panelists?
So can I take that? Yes, I've seen patients of sarcoid. They may not have much subretinal fluid, but the hyperreflective dots are definitely much more, and they involve both the choroid and the retina, outer retina. This is unlike TB. TB, I think, directly causes a fuzzy infiltration of the outer retinal layers, but does not have those hyperreflective dots. So I think that's a very useful point.
I think it can be useful because those tend to disappear with treatment also. So, and they tend to disappear faster than the resolution of the granulomas that are present. With regards to the previous talk by Francesco, there was a question that was asked with regards to, since we're able to image so well the area around the retinal surface, should we be able to differentiate the type of cell infiltration we can see there in terms of whether we're seeing pigment, whether we're seeing, the types of inflammatory cells that may be present in the case of infection versus inflammation? I know you answered, but maybe you'd like to give it to the larger public.
Yes, so I think there are a couple of groups that are actually doing it, and I think I was analyzing something, and it's like the paper I think that Alessandro showed, the IOVS paper in the anterior chamber. So same concept. We can be able to measure the size of those cells in the vitreous. But at the end of the day, I don't think the clinical utility is huge, because if I have to differentiate a lymphoma from, for example, a toxo, that's not what I would use. I wouldn't measure the cells. And then plus, for now, you have to export everything into ImageJ, Fiji, or MATLAB and create an algorithm. And it's quite time consuming. And yeah, clinical utility is not great.
So again, it's time that is being the issue, isn't it? And but granulomas at the source of the retina might be useful. You showed it with toxo, but you can see it in other conditions in inflammatory disease. And certainly in lymphomas, you could see it just above the RPE. And so, being able to look at that would be good. And I have maybe one comment with regards to your theory of the Cloquet's canal. I wonder if because you're seeing these fenestrae, or this connection between the premacular bursa and the one that is over the optic nerve, the Cloquet's canal doesn't survive in everybody. In many people, it atrophies completely. So is this an indication that in fact there is a connection to the anterior segment? And have you tried looking at that, the preservation of Cloquet's or not?
We haven't, because we actually detected the Cloquet in all our patients. But as I was answering Dr. Kempen's question, and this is just a theory, and our numbers are not huge, so we need a bigger study to prove if this theory is true. And even if it's true, I'm not saying this is just the cause. It's just one predisposing factors for anterior uveitis patient to getting CME. I have to say that Cloquet canal we identified in all our patients. Yes, both from here and from
patent, because that would be the other question, whether it's still open. Yeah. So maybe you need to find some unfortunate patients that pass away at an early age, and then use some dye, as did Worst in the time, to find out how well it goes to the posterior pole. But that would it's an interesting theory, I have to say. Before, we're getting a little bit over time, but maybe any of the speakers have some final comments, or things they would like still to say about their presentations or that of other people.
Mark, I would like to make a comment about vitreous cell differentiating between the etiology. I think you can look at it clinically also. The cells are large, it could be lymphoma. The cells are small, they are inflammatory. because we have lots of friends attending from Africa and many other countries where these imaging modalities may not be available. And we don't want to give them impression that you need actually the gadgets to tell you what it is. These gadgets will help you, but primarily your clinical acumen still will tell you most of the things, which might be enhanced with these understanding. That's on.
I agree. And I think an important point if we talk about lymphomas, these are clumps of cells. They tend to form pearls on a string. And what I've always found was that with lymphoma, the number of cells doesn't correspond with the vision. The vitreous looks worse than what the real vision and the appearance of the retina is. And that's a nice differentiating factor. And it also plays a little bit also with some of the infection causes. I mean, if you're looking at, for example, when we talked about Candida, it tends to form pearls. Toxo usually involves the vitreous, but there are some forms that involve just the retina and the choroid, and you see no vitritis. It all depends on the level where it is, and of course, a big level of suspicion. And I think, it was Francesco that showed early on a case where it's the PCR, I believe, that you had done that sort of confirmed the diagnoses. And all of this is indicative, but it's true that we don't need it, and we've practiced for years without it. On the other hand, it'll be nice to have these tools as they develop and get closer for us to make it a lot easier.
I think
and maybe one final
to predictive algorithms, AI based. So we need this basic information for developing that kind of.
And for those people who can participate, it would be great. And so maybe one of the debates that will come along, you don't necessarily need to answer, but with the flare meter, we thought, we can give up cells because the flare is more sensitive. And it is to some extent if you can measure very well, but then you can get reflectance from the cataract as it develops. And yet, we all use cells because we know what to do with cells, as Marion said. So what's better, measuring cells, measuring flare, or do we need both? And I'll let people decide on their own. I think we all have our ideas at how we should do that. And maybe as an aside there, cells are easy to assess when there aren't too many. The big problem comes when you get to grades 3 and 4 because it's very hard to be able to distinguish those. And I find that flare becomes easier as there's more flare present. And so maybe there's a compensation between those two. Any final comments from anyone? Well, if there aren't, this was a fantastic session. I think I've learned a lot, both from the content and also from the titles. I think, in future webinars, people will have to be very creative to be able to do better than this group of young, very enthusiastic researchers. And we're looking forward to reading more and hearing more from all of you. Vishali, any comments?
Yeah, no, we look forward to seeing everybody on 16th, where we have a special webinar by IUSG on COVID. So that won't be a part of the series. So you will not have CME credit, but rest everything is the same. And it will be really nice up to date on COVID. And we have Manfred. Welcome, Manfred. Just say, Manfred, conclude the session, please.
Well, it was a fantastic session. Thanks so much. I've learned a lot, and congratulations to all of you. A lot of pleasure. Thanks.
And see everyone on 16.
Thank you
Okay.
so much. All the
Thank
best.
you.
Thank you. Thank you.
Have a
Bye.
good evening and a
Have a
good
great remaining
afternoon
weekend.
and a
Bye.
good weekend.
Bye.
Bye-bye.
Bye.